My name is Kåre Norgard, and the purpose of this video is to show you how you can get happier customers and document your quality. Because we think we can get a lot happier customers in treatments for instance, breast cancer, because now they can get a link to their own treatment and control it and be on top of it. It's my body, therefore it's my treatment, my breast, my quest, etc. We think that customers will be happier if they can be in control of their treatment and not just have to trust their doctors, but also be in control and then better involve their loved ones. But first, I would like to substantiate that we think that customers will indeed be happier if they had this. So I'll start by showing 3 testimonials from people who have had breast cancer. And then I will show you how we make it possible and why it hasn't been possible to do that so far, but now it is. So let's switch to the testimonials. We found 3 testimonials published by Mayo Clinic.
Experts or doctors or care providers who come and speak or share their knowledge and experience is something that I'm looking firsthand. So instead of going and buying a book or trying to read online and not knowing if I'm getting the correct information, coming here once a month, being with others who are going through similar breast cancer or other cancer treatment like I am, being surrounded by them and sharing our experience, laughing, talking, along with a cup of coffee, and at the same time getting all the information that is pertinent to my treatment or something I may have missed, I may have not even known. All that information that they provide is vital, and I look forward every month coming and being part of this Coffee with Company.
So let's hear the next testimonial, and then we'll talk a bit about what we think they really would have wanted and what they would have appreciated. The next patient comes here.
I was scared because I didn't have answers. And once I got the answers from Mayo, then I was at peace with everything, what was fixing to happen to me. They gave me a plan of what they were planning on doing. And I was like, okay, let's do this. I also have 2 other friends that also went through breast cancer at the same time I did, and we all had the same type of breast cancer. So I already had a support group, and we would just talk and ask each other how we're doing and what's going on with your treatments. And so I really do think that having other people, talking with other people who've experienced the same thing as you, just kind of makes you feel like, okay, I'm not alone. This does happen to ordinary people, and it is what it is.
So let's have a talk about what these 2 people have said. So they very much would have appreciated, or they very much appreciated the information they would have. And the first person talked about that she would have looked online and in books if she didn't have the information. And now, I don't think we can prevent people from looking online, but we'll supplement so that what they look for online is relevant and not all the irrelevant stuff. The second person was actually scared until she got information or answers to her questions. And she appreciated that Mayo Clinic, the hospital, gave her a plan, which made her having peace of mind and said, okay, let's follow that plan. So what we think they would appreciate is written information to supplement whatever they're doing so that they can actually track their own treatment, have a plan, have answers, get vital information pertaining to them. Then they mentioned the importance of involving support groups or loved ones or relatives in their treatment to support them. And one thing to be very cautious about is that you may think that somebody else's breast cancer is similar to yours. Like, for instance, somebody has chosen not to have chemotherapy, then you think you can also choose not to have it. But there you have to be careful because the cancers may not be completely equal, even though you think they are. So it's very important to get pointed information that pertains to your specific case. Now let's switch to the third testimonial. This is actually a man. And because males can have breast cancer as well, it's not at all a rare disease. 1% of all breast cancers happen to men. Most men are not aware that it's a common disease they are having. So maybe we should do a little more for men. But let's hear what he has to say.
Follow. The other thing that I would tell people is, and this is a big one, I tend to be very self-sufficient, but you really want to have a support person come to those appointments with you, because there were times my wife would say, oh, she said this, and I wouldn't have that in my notes just because there's so much. And so having a good support person to both be there for you, but also attend those appointments is really helpful.
Okay, one thing that he says, which is very important, is that there's so much information and it might have been said to you a particular point, but you may not have noticed. Then people who is not familiar with this breast cancer issue might think, why didn't the hospital give him that information in writing? And that's we'll look at in a moment. It's simply not possible, because the specific breast cancer treatment case and the things you have to pay notice to may differ from everybody else, be very specific to your case, and therefore it's not possible to write it beforehand, and therefore the oncologist or the doctor has to tell it, and the patient has to note it down in order to understand what is the case. But so what we think is that they would very much appreciate getting information that's specific to them, and we have to make it very specific to them. And so far, this has been regarded as something that was not possible, but now it is. And I'll show you an example of what we think they would have appreciated. So we think they would have appreciated something like this. That would take them all the way through a breast cancer treatment. So what you see here on your left is a full plan that takes you through steps you have completed, like these. And then the future steps without the check marks are these, which will take you through the other parts of the rest of the treatment. And then on the way, you will see the major decisions happening. Now we are in a mode where we are both the doctor and the patient at the same time. It will obviously have to be divided. But one of the things that you have to notice is whether you are at risk, whether you have an elevated genetic risk. So one of the steps of the flow is to assess that risk. And I'll select that we would like to make that assessment. If we have a bracket test, we're at risk, and there's no further things to do because we have an elevated risk. We can already conclude it if the bracket test is positive. And the tool will say that if you say yes to this, then you're at risk. If you say no to this or don't have it, we'll have to look at your family. And you can either have had no breast cancer or ovarian cancer running in the family, then you're not at risk. Or one or more family members can have had breast cancer or ovarian cancer. So let's say that somebody had breast cancer. This somebody was your mother. She was born at this point in time. But the important stuff is, what age did she have when she had breast cancer? If she was 42 when she had it, the tool will say that you are not at risk. And this is because a lot of the breast cancer knowledge says that if only one member of your family had breast cancer, this was your mother, and she had it at the age of 42, then you are not at risk. And all these conclusions are dimmed out here and summarized up here. Whereas if she had it already at the age of 37, then we'll see that the tool obeys one rule, which is that if one first degree female relative was diagnosed with breast cancer younger than 40, she was 37, and first degree is, for instance, your mother or your sister, then you're at risk. So you'll see the tool actually summarizes that you're at risk. So let's go ahead with this. You can specify others if you want, but this is already a conclusion that you're at risk. Then that's one step. You can then go ahead and key in the result of the mammography. So it's an IDC, for instance, that you're having. And it's 12 millimeters wide, in which case the tool concludes that it's a T1C breast cancer. If you involve the skin, it's a T4 cancer. Will not do that. So it's still only a T1 cancer, and you have it in your, say, right-hand side. And then the tool will, at certain points in time in the flow, it will allow you to extract a summary. We have assessed where the summary is nice to have, and this is one of these points. And we'll just say there's a lot of yes, no questions. There's a lot of data about your height and weight. We previously keyed that in. And then there's a risk assessment and a date, November the 1st. So you can print it or close it. We'll just go ahead. Excuse me. And then the next step will be which kind of surgery do you need to have. So if we didn't have radiation in the past, if the tumor is well delineated and there's tissue around the tumor, it will still say that we should have a removal of the whole breast. And this is because there's an elevated risk of having breast cancer. So just for the sake of trying it out, if we go back and change that, we know that if we said the mother was 42 when she had breast cancer, then it will conclude that we don't have an elevated risk of breast cancer. And if we go ahead with that and repeat the questions, we didn't have breast cancer, we didn't have radiation in the past, the tumor is well delineated, and there's tissue enough around the tumor, you'll see that the screen currently says whole breast removal, but once I click this, it will switch to breast conserving surgery or lumpectomy, which is what we recommend because all of the factors behind that recommendation are now in place. And then we can choose that because it will record as well what we actually choose. So we could choose to have mastectomy still, or we can choose to have lumpectomy, which we choose to do. And then it comes out with a lot of documentation, which is not possible because of the many combinations that exist. There are actually 300 of those yes or no questions that we just went through. I'll go through that in a moment. And all these questions will have as consequence that if you answer differently, you'll go through a different treatment. Therefore, the ability to write a documentation that pertains to you is not there yet. Now it is. We can do that because we have a way to convey that text so that it fits your case. So this is a tool that now makes it possible to have a link together with your diagnosis so that you can follow and track your own treatment as it evolves. Now, how is that possible? I will go through that now. So we assume that this is what they would appreciate if they had that. Now, I'll tell you how it is possible and what is new in making it possible and why it was not possible so far. And the way I'll do that is that I'll look at a breast cancer treatment. So any breast cancer treatment is a combination of those arrows that you see here in blue. That's on a very high level. the configuration of a breast cancer treatment is summarized in the green boxes. The problem comes here. There are 300 questions that can be yes or no, like, is it a man or a woman? If it's a woman, is she menopausal or not? Is she pregnant if she's premenopausal? Is he or she young or old? Did she have or he has had radiation in the past? Is there an elevated family risk, etc.? Is the cancer big or small? Is it a single or multiple tumor? Is it invasive? Is it ductal or lobular? Is it grade 1, 2, or 3? Is it ER positive? ER meaning estrogen receptor positive or negative? Is it HER2 positive? Are the lymph nodes hit, etc.? And these are just 16 out of those 300 questions that if you answer each of them differently, you'll have a different treatment. Therefore, the number of ways you can answer these 300 questions is approximately 2 to the power of 300. And that's a huge number. And this is why it is very hard to come by a configuration tool that can configure so many combinations. We now can. We have introduced it in the QGPS platform, which we liken to a GPS. When you make a route plan, you can go many ways from A to B, but the shortest way is, or the best way is given to you in the GPS. And we think that this is what we would like to do in healthcare, a GPS that takes you to being cured, and therefore it's called QGPS. It holds an unlimited set of variants because the software doesn't explode in complexity when the problem size grows and approaches a big problem with 300 barrels. It represents the solution as a project plan, and the plan can be updated during its execution. That means you might be wiser and get new information during treatment. So the problem you're solving is changing as you solve it, and the project plan changes while you execute it. Just to give you an idea of how this is possible, we'll have a closer look at a breast cancer treatment, and we'll introduce the concept of a decision matrix in doing so. So at a high level, when a breast cancer treatment must be configured, you will have to put together a treatment plan that composes or is made up of these 9 main activities, 1 being neoadjuvant and 9 being radiotherapy. Neoadjuvant is something you would have if the tumor is large. Neoadjuvant means that you have to have chemotherapy before we proceed with a surgery. Now, if we proceed with surgery, it's either lumpectomy or mastectomy. It has to wait for step 1 to be completed before it can start. So therefore, we have noticed that there's a predecessor of 1. Neoadjuvant has to be completed, if it is there, before you can do the surgery, lumpectomy or mastectomy. Lumpectomy, you would have to choose is if there is a low, or if you can say no, to the family risk. And mastectomy, you have to choose if it is either large or there is a family risk, a little simplified. Then each of these surgery steps, which are mutually exclusive, will set whether the lymph nodes are involved, and breast conserving surgery will be set if you have lumpectomy. And then you can see that lymph node surgery, step number 4, is relevant if the lymph nodes are positive or involved, and it has to wait for either lumpectomy and mastectomy. Therefore, 2 or 3 are the predecessors of step 4. And so it proceeds. You must have lumpectomy if it's ER positive and you're premenopausal, and you must have aromatase inhibitor followed by bone loss treatment if it's ER positive and you are not premenopausal. And both of these steps have to await chemotherapy, or the step number 7 is the predecessor. because chemotherapy, if it is relevant, has to be completed before you can start tamoxifen or aromatase treatment. The decision rules behind having chemotherapy are a little complex and involves a lot of variables. Trastuzumab involves whether something you must have is if it is HER2 positive, it awaits the lymph node surgery and part of the chemotherapy. And radiotherapy you must have, it awaits chemotherapy if it's there, and you must have it in case your lymph nodes are positive or you have a breast conserving surgery. So this matrix introduces at a high level and an overly simplified level how you can find out which combination of a breast cancer treatment you must devise to any particular patient. This introduces the concept of a process matrix in that you have all the steps at a high level to the left and a decision matrix that tells you when to include a step in the treatment. In order to explain what the process matrix is for a simple workflow with only 3 activities, you can liken it to a flow chart. So we have depicted a very simple workflow here with 3 activities and decision point in the middle, and the process matrix is depicted here to the bottom right. It's the same workflow, so you can see that the process matrix is like a flow chart, it's just a matrix. But the problem is that when you grow to a complex problem with a complex solution, you have to only do it using a process matrix. And that's because if you diagram all workflows by how complex the problem is, that's the first axis. And then given that you know the given that you know the problem, how complex is then the solution to that problem? Then simple problems having simple solutions can be diagrammed by a flow chart. And this is why we have a flow chart here. Whereas complex problems with complex solutions, such as treating a breast cancer, or is positioned in the upper right-hand quadrant of this diagram, the treatment quadrant. And as we saw in the previous presentation, a cancer problem is characterized by 300 approximately things that can independently be yes or no. So it's a pretty complex problem to solve. You have to characterize the problem by 300 variables. And the solution, that is the cancer treatment, is one that has many, many steps, 250. So a cancer treatment cannot be handled by a flowchart. So even though you would use a flowchart to explain the process matrix, you have to diagram a cancer treatment only in the process matrix. And this is why it is new and why it hasn't been done in the past, because all workflow engines and rule engines in the past have been based on flowchart as the data model behind the workflow. Now, if we describe a breast cancer treatment in the process matrix, then each row is an activity, and we have collapsed most phases here to the left, except one, and we have highlighted what it consists of. Then there are 250 or more rows in this matrix. There are 300 columns in the decision matrix, as you just saw. So it was a simple extract that you just saw. The totality is 300. And then there's a lot of data. And based on this data are recommendations on the decisions you have to make. So this is the decision whether to recommend mastectomy. It's based on a lot of factors here, and we have just highlighted 2 of them in the previous presentation, and that is whether the tumor is big or tumor above threshold, and whether you have family history of breast cancer. But it's a little more complex, but only those go into that decision. And this is one of the steps in the overall flow, the recommendation to have mastectomy or lumpectomy. And if you summarize everything that's in this matrix, we come up with these headlines. And if we take them from the top left after diagnosis, and then there's data, and we'll not talk too much about it. At surgery, there's adjuvant configuration, there's planning, and there's adjuvant therapy. But if we take the first one, BRCA, you have already seen it. It's a step which finds out whether you have an elevated family risk. Then there's the tumor characteristics, which is a step that summarizes what kind of tumor we're talking about. You already went through it. Then there's the decision on what kind of surgery you should be advised to have. Finally, it will, in this section, find out whether you should have medication or chemotherapy first before the surgery. And there are a bit more decision variables to take into account than just whether the tumor is big. But it's all there. Then it configures the adjuvant treatment. It allows you to key in or extract from the health record the pathology report and make conclusions that correspond to the data that's in the pathology report. And since it concludes that it's ER positive, HER2 negative, grade 1, you should have a gene test from which it will conclude whether you should have chemotherapy. And in this case, with this screen print, the gene test says that you will benefit from chemotherapy. And so it will continue saying, okay, we offer chemotherapy, and report whether you actually choose chemotherapy. And finally, we will offer radiation therapy because you have had lumpectomy, in which case you should have radiation because you have breast conserving surgery. And finally, in this presentation, it devises the whole treatment as a project plan. So it plans to have surgery on the October the 31st. Then the chemotherapy must wait for 21 days after surgery. Therefore, the chemotherapy will start on November the 22nd. It will last, in this combination case, for 126 days, so until March the 28th, on which date you can start tamoxifen treatment, which lasts for 10 years, as you see here, and you can also start radiation therapy, which will last for 35 days, and so on. These are just to give you an impression of how much information there is in this giant breast cancer treatment solution. And to give you an impression of the kind of information that's there, we have done a few screenshots of the exchange that happens when you pull the full data record. And this can be pulled by the EHR system, the electronic health record, EPIC, for instance, to the system or from the system. But it can also be handled as a standalone system where you just ask your doctor to give you all the information, then you or the doctor will type it in and you can follow all the decisions. But just to give you an impression of the wealth of information that we handle in this tool, we have made a few screenshots here from that particular step where you extract all the information that pertains to your specific breast cancer case. And some of it you have already seen. And then it extracts a lot of other information that we won't talk a lot about. I'll just pause here after comorbidities, because it will then extract information that calculates the correct dose of chemotherapy. This is a point where many doctors get it wrong or nurses get it wrong. And since the tool handles the weight and height inside the tool, we can correctly calculate the chemotherapy dose. For instance, if you have a combination, it's typically 3 agents that together make up the chemotherapy. One of the agents is, in this case, cyclophosphamide. It's a weight-dependent drug, and we know the weight, so we can correctly calculate the number of milligrams you should have for the first 5 days, and then the subsequent interval is 7 days. The other 2 out of 3 agents are fluorouracil and doxorubicin, which are body surface dependent agents. And we know the body surface because, again, we have the height and the weight, so we can compute that, and then we can compute the correct dose in milligrams of these 2 agents as well. And then the good thing about this tool is that if you change, for instance, your body weight, it's very often that people lose some weight during treatment, then the doctor or the nurse will get a reminder saying, hey, some of the rules are based on data that now has changed, so you should reconsider the dose. So a frequent error is thereby avoided in that the dose must be updated as you change weight. And this is how the tool also works. Finally, it will ensure that the radiation department undertaking the radiation treatment does it in the correct doses as well. So the conclusion of this presentation is that putting it all together, we can now give a person-centric documentation, and we can view the whole treatment, and thereby she and her relatives will be a lot happier because now she can supplement the trust and all the other things she does with full control of her own treatment. My breast, my quest, my body, my treatment. So I'm in control. The good thing is that this guy, well, the clinicians will be helped in avoiding errors and can document that they don't ever make an error. And this is because if we home in on the treatment decisions, for instance, the lumpectomy, whether we should recommend lumpectomy or not, we can see that the tool has a rule behind that, and that rule is in a database. It's based on data, and since we also collect the data and timestamp it, and we know who gave it because that person is logged in, or it's a system, then when we choose or recommend to choose lumpectomy, we can exactly say that this is the data we had up to that point in time, and the decision we recommended was aligned with that data and in conformance with the guidelines. So not only was it optimum, it was conformant, and thereby the doctor can or the hospital can document that the treatment was always correct at any point in time. So if you are burdened with cost of malpractice, then you can slash this cost because nobody can sue you for malpractice anymore because you can document your quality. Going back to the high level and just finalizing this whole presentation, I'll say that today the treatment guidelines are many and different. So I'm from Denmark, and in Denmark we have certain guidelines, and in each country they have special guidelines or specific guidelines. I think the best ones are in the US, but the point is that in the future we'll merge them and have the best guidelines for the whole planet, because breast cancer is the same disease all over the planet, and we should be treated the same way. So the perspective is that in the future, you will have a global database and one database only, as you have for Google Maps and the GPS. You have one routing database, and everybody benefits from this single database and gets the best advice they can get. And they can get it in their own language, because we have also implemented that the tool works in many languages. So it might take some time until the US and Denmark aligns, for instance. And in the meantime, if you choose US because you are in the US and your family speaks, some of your family speaks Spanish or French, we can let them access your treatment in their own language. So we very much think that this will start a new era of being on top of your own treatment, my treatment to my body, my breast, my quest. And this will enhance the control or the feeling of control you have and the peace of mind. And we can see from the testimonials that that is what patients would want. So we would like to improve healthcare, starting with breast cancer, together with you, and we very much look forward to that cooperation. Thank you for listening.